Time right now is 4:39, and as you've been hearing in the CBC News, doctors and nurses still aren't washing their hands enough. The WRHA's goal is to have 80% of their medical staff wash their hands between patients. But a new report shows only 73% compliance with nurses and just 66% compliance with doctors, and that's at our best performing hospital. Daryl Horn is a systems safety advisor for healthcare system safety and accountability. That's a business run out of Hamilton, but he joins us now. Good afternoon.
Good afternoon as well.
So what's your reaction to those numbers? 73% of nurses and 66% of doctors at our best performing hospital.
Well, to tell you the truth, it doesn't concern me that much at all.
Really? Why not?
Hand hygiene is only one of a whole panoply of interventions that are necessary in addressing the issue of hospital-acquired infection. First of all, it's impossible, almost impossible, to overstate the size and scope of this problem. Experts in the field right now believe that as many as 18,000 Canadians a year are dying from hospital-acquired infection, and the napkin math tells us that 1 or 2 Manitobans are expiring every day. Those are just the people that are dying. The notion that a campaign that was launched by the WRHA back in May, that hand hygiene somehow the root cause of this problem. Mm-hmm. If only we could get those dirty doctors and nurses to wash up, that we could significantly address the problem, is a canard. Okay. It's a specious notion. There are so many different contributing factors to healthcare-acquired infection that addressing only one, it's not going to make a significant dent. And I think probably the most telling thing, Dr. Michael Garda with the University Health Network, acknowledged as one of this country's leading experts, if not the leading expert on issues of infection control, monitored for the past several years an ever-increasing and tremendously expanded rate of hand washing in Ontario hospitals, and has noted that it has not resulted in a commensurate decrease in the incidence of hospital-acquired infection.
Okay. I think, though, that from a patient perspective or an outside of hospital perspective, when it's something as basic as hand washing, maybe we take that as a representation of how seriously hospitals are taking in-hospital infection. And if that's one part that we can understand and have some sort of control over, we hope for that. So why is it so hard to get medical staff to wash hands in between seeing patients at a rate that is being asked for from the WRHA?
Well, it's something that's been studied very well, and one of my colleagues, Professor Eric Halsnagel of the Southern Denmark University, written a book on the subject called The Efficiency-Thoroughness Trade-Off. We all work in just about every environment under a cruel rubric of not enough time and too much to do. Now, in a lot of different environments, if you're preparing tax returns, you can stop the line.
Right.
You can't do that so much in an emergency room. You can't do that so much in a busy ward in the morning when you've got 30 patients who need medication and breakfast and turning and bathing, and the flow doesn't stop, and the demand is constant. And under that harsh influence, something's got to give. Something that, we'd all say, well, that's a simple thing to do and it's an easy to do. But once again, in that environment, the necessary trade-offs between efficiency and thoroughness, we have to make compromise. The environment is contributing a significant amount to this, so dealing with contamination in the environment is important. Sterilization of instruments, all the different sorts of decontamination procedures. These are all incredibly important things. And when Dr. Garda says that, more diligent hand washing isn't having an effect, then I think the question that we need to ask in Manitoba is, are these initiatives moving the needle? If we increase the rates of hand washing 10%, 20%, have we decreased infection by 5 or 10%?
Have we seen any change in the number of in-hospital infections over the past few years where we have seen some slight changes in hand washing?
It's curious, the lack of information. And we need more transparency in this regard to find out about what the true rates of hospital-acquired infections are, what the types of infections are, serious study of what any of these sorts of interventions are doing to actually move the needle, because none of that information is part of the discussion that's been going on in the past day. Everything's a secret, and secret organizations are not safe organizations. Safety depends on openness and transparency, sharing of information. Okay. So we need to start talking about the size and scope of this problem. We need to start talking about the scientifically sound, epidemiological, effective measures that need to be taken. And we need to hear a plan. And it's not just the WRHA's responsibility. I'd say that the Minister of Health, in her position of oversight, bears a significant responsibility here as well. Okay. To start talking about these issues beyond name, blame, and shame. Now, one of the things that I've written about recently is the notion of workplace safety and health legislation and the role it might have to play in a solution to this. You have the right to refuse dangerous work that is dangerous to yourself or to others under provincial workplace health and safety standards. And if you're a busy nurse or a busy doctor and you don't have time to wash your hands between patients, I wonder who will be the first person in a healthcare profession to stand up and say, no, it's not safe for my patient. I need more time.
Is that what needs to change? Do we need to hear doctors and nurses stand up and say that they need more time?
Yes. Absolutely.
Thanks a lot for this, Daryl. Really appreciate it.
Thanks, Ismail.
Daryl Horn is a Systems Safety Advisor for Healthcare System Safety and Accountability.
I'm Janet